Good morning. I'm Michelle Lavander, Director of the Center for Health Journalism at the University of Southern California. Thanks for joining us today for our Health Matters webinar, How Our Environment Gets Under Our Skin. This webinar is offered thanks to generous grants from the Commonwealth Fund and the National Institute of Healthcare Management Foundation. A growing body of research teaches us that where we live matters when it comes to health and well-being. This webinar will explore how neighborhood conditions such as access to healthy food and the experience over time of racism and poverty can influence everything from average lifespan to chronic disease rates to birth outcomes. At the same time, an emerging field of science shows us how these health drivers can affect us down to the level of our DNA. High levels of chronic stress associated with discrimination, childhood adversity, or even caregiving of an ill family member are tied to shorter telomeres, a new measure of biological aging. These experiences of life stressors are literally causing what some call weathering or premature aging that can be faster than actual biological age. Here to help us understand and report on these issues are two distinguished experts. Dr. Anthony Iton is Senior Vice President for Healthy Communities at the California Endowment. Previously, he served as the Director of the Alameda County Public Health Department and County Health Officer. His enduring interest is in the health of disadvantaged populations and the contributions of race, class, wealth, education, geography, and employment to health status. We'll also hear from Professor Alyssa Eppel, who heads up a center in the Department of Psychiatry at the University of California, San Francisco. Her research explores the mechanisms of aging and how the science can help vulnerable populations. Before we get started, I wanted to share a few operating procedures. We'll hear first from our speakers, then we'll open it up to your questions for the final 20 minutes. Because we have several hundred people participating in this webinar, we'll ask you to comment in the question field in your control panel, and we'll read out your questions. If you have technical challenges, please also text us through the comment or question field in your control panel. You can tweet about this webinar at the hashtag #PlaceMatters. Thanks so much. We'll start out with you, Tony, or Dr. Iton. Please let us know how you interpret all this.
Thank you, Michelle. I'm assuming I can be heard. I love talking to journalists, so I'm going to jump right into this. And, I entitled this, How the Environment Gets Under Our Skin. And, the fundamental question that occurred to me when I first arrived in the United States, actually from Canada, and landed in East Baltimore to go to medical school in Maryland. Seeing the conditions in East Baltimore, I was forced to contemplate this idea of, in the United States, does your zip code matter more than your genetic code when it comes to your health? And years later, when I became a health officer and director of a health agency, I had the privilege of being the registrar of all births and deaths in Alameda County. And a death certificate is a very useful document for analyzing patterns of death. On a death certificate, you know what somebody died of, the cause of death, you know the age they were when they died, you know their race, ethnicity, and you know where they lived. And those four pieces of data can actually give you a very compelling picture of how patterns of death play themselves out over years in a jurisdiction. And so we took 500,000 death certificates in Alameda County and analyzed them over a period of almost 60 years. And one of the things that you see when you do that is, and what I'm showing you now is a map of Alameda County, which is shaped like a boot. And the foot part of the boot is the older part of the county where you have Berkeley and Oakland. And then down towards the heel, you have a freeway that's a 1970s era freeway with suburbs along it. And then along the laces of the boot, you have 1980s era freeway with suburbs along that. And the back part of the boot is mostly rural. So when you do an analysis at the census tract level, which is what these boundaries are showing, there are about 10,000 people living in each census tract, which is approximately a neighborhood. You can calculate the average age to which somebody could expect to live in any neighborhood in Alameda County, and that's what this map shows you. Those red areas are neighborhoods in which people can only expect to live about 74 years. In the green areas, people can expect to live about 80 years. And in the yellow areas, people can expect to live between 74 and 80 years. And this was a somewhat radical map at the time that it was published in the early 2000s. And people wanted to understand what was happening, in these neighborhoods. The San Francisco Chronicle ended up putting the map on the front page, and it stimulated a lot of policy conversations. Amongst some of the conversations were, is Alameda County unique? And we set out to sort of prove that that was not the case. And so we took our Alameda County map and we went to other parts of the country, starting with Baltimore, where I'd gone to medical school. And in Baltimore, you see neighborhoods with life expectancies in the high 50s, as well as others with life expectancies, approaching 90 years of age. We went to Cleveland in Cuyahoga County and found a neighborhood with a life expectancy of 61 years, and another one just a mile and a half away with a life expectancy of 89 years. So dramatic disparities across that city. We also went to New York City, found similar findings. We went to Seattle, King County, again, found similar findings. Los Angeles, similar. Minneapolis, St. Paul, Boston, Philadelphia, San Antonio, Denver, St. Louis. Pretty much everywhere we looked, we found these life expectancy gaps of 12, 15, 20, 25, and in a few cases, even 30 years across neighborhoods in the same city. And so it's clear that Alameda County is not an exception. This is the American pattern. This is how life expectancy is distributed across places in the United States. We subsequently went ahead and did every census tract in the state of California to look at life expectancy differences. So we've mapped all of that. And more recently, the National Center for Health Statistics has mapped every census tract in the United States. And what they've concluded is that there's no state in this country that has less than a 20-year life expectancy gap between census tracts in their state. So as you can see in this graphic here, you see this range of low life expectancy neighborhoods, some going down into the high 50s in New York and Oklahoma and West Virginia. And then on the right side are the high life expectancy neighborhoods where you have very high life expectancies, including in Maryland and North Carolina of 90, 95 years and beyond. So this is the American pattern. For any of you journalists that are interested in looking at your region, you can go to the National Center for Health Statistics website and you can put in, essentially your state or the region that you're interested in, and actually look at the life expectancy difference across your region or wherever you're reporting. Going back to Alameda County, the other thing you can do with the life expectancy map is you can correlate life expectancy with poverty. And so again, the boot shape on the top left is Alameda County life expectancy by census tract. And on the bottom right, you have poverty rates, household poverty rates by census tract. So you can correlate those two things. So what you're seeing now is what's called a bivariate correlation, which is just a simple comparison of life expectancy to poverty rate to see how those two factors work together. And each of those blue dots that you're seeing right now is a census tract in Alameda County. And as you move from left to right, you're moving from relatively rich neighborhoods to relatively poor neighborhoods. And what you see with that black line is that life gets correspondingly shorter. So as you get to the right part of the graph, you're dealing with high poverty neighborhoods that have relatively low life expectancies. And we call this a death tax. And that's the price that you pay in loss of years of life for living in a low-income community. And it's not just Alameda County, as I mentioned before. We did this for the entire San Francisco Bay Area. We did it for the entire state of California, in fact. In the Bay Area, we calculated, looking at the slope of that line, which is just measuring the rate of decline of that line, we calculated that every additional $12,500 in household income buys you a year of life in the San Francisco Bay Area. So that is a way of conveying to people the impact of income on life expectancy in a region. One of the other things that has happened recently is the Center for Economic Studies, which is a division of the U.S. Census, working with a group of researchers, including a very prominent researcher by the name of Raj Chetty and his colleague Nathan Hendren. They've put together an analysis of census tracts in small geographical areas, looking at what they call opportunity. They're calculating social and economic mobility based on about 50 million U.S. tax records. And what they show are dramatic differences. On the left, I'm showing you one of their images, which has down to the census tract level Los Angeles, and it shows you dramatic differences across that city in terms of opportunity. And that is the likelihood that somebody born into poverty can escape poverty, within about 30 years. And they did this by looking at tax records from the 1980s to roughly the present and comparing the income of people born in the 1980s depending on the income of their families. And then the map of the United States you see on the right there is also, it's a similar analysis, not at the census tract level, and they do this sort of thing they call commuter zones, and they show dramatic differences in economic mobility across the United States. And you can look at the Census Bureau now and look at data for any census tract in the United States to get a sense of economic and social mobility in that place relative to other places in that community. And one of the things that many people don't understand is they say, well, you live in a bad community and clearly the life expectancy is low and opportunity may be low. That's just bad luck. What you need to do is just move because this is just a random thing. Some neighborhoods are going to be good, some neighborhoods are going to be bad, and your mission should be to move from a bad neighborhood to a good neighborhood. And in fact, Raj Chetty's work does show that children that move below a certain age from a poor neighborhood to a relatively wealthier neighborhood do better than their peers that stayed behind. But the question is, why don't people just move? Well, many people didn't have the choice. And this is a very quick example of what's called a racially restricted covenant. I'm going to read it to you. No person or persons of the Mexican race, whatever that means, or other than the Caucasian race shall use or occupy any building or any lot, except that this covenant shall not prevent occupancy by domestic servants of a different race domiciled with an owner, tenant, or occupant thereof. That's a racially restrictive covenant, which is a covenant that runs with the land. I have had 3 houses in Alameda County, and I'm an African American, and all 3 of those houses had racially restrictive covenants on them, which meant that I was meant never to own those properties, essentially for eternity, because these covenants run in perpetuity. And this was not just private actors doing this. This was federal policy, and this comes from the Federal Housing Administration's Underwriting Manual in 1938, where they say it is necessary that property shall continue to be occupied by the same social and racial groups. Many of you know about redlining, and redlining was a practice, which I'm going to show you in a minute, which basically enshrined some of those essentially apartheid mentality into federal government policy. What I'm showing you now is Alameda County and a number of racially restrictive covenants. We did a bunch of research and looked for racially restrictive covenants all over Alameda County. We ultimately stopped because there were so many of them that we couldn't keep up with them. There are thousands of them all throughout Alameda County, and they were legal and enforceable up until 1948. What I'm showing you now is a redlining map of the city of Oakland, and I'm showing it to you because I want you to sort of like spot the patterns. So redlining is a practice which looks at essentially evaluating neighborhoods based on their grade. They're called residential security maps. They were essentially authorized by the federal government and carried out by employees of the federal government, where they went into a community and they graded neighborhoods based on first grade green, second grade blue, third and fourth grade were low grade. And in those third and fourth grade, particularly in the red zones, the red-lined areas, the federal government wouldn't guarantee mortgages or insurance. So it made it very hard for people to essentially acquire property that could gain equity over time, or to get mortgages that were backed by the federal government. So what we did using GIS, Geographic Information Systems, is we took that redlining map that I just showed you and transposed it into GIS, and that's what I'm showing you now. It's overlaid on the city of Oakland, and what we wanted to do was use the census to see where African Americans could move over the years in Oakland. And so this first map, each of those black dots represents roughly 200 African Americans. And you see African Americans starting to populate in the 1940s in those red-lined areas. And this is 1950. You see the concentration developing and African Americans having a very difficult time moving out of any of those red-line areas. And then this is 1960. And the reason that this is significant, I like to tell people in public health, you don't have to be a rocket scientist, but you do have to be able to spot a pattern every now and then. Because if you remember that map I showed you earlier, where we had those red areas where life expectancy was low, well, here's one of them, and here's the second one. And the overlay of these things is very telling in terms of people not being able to move because of policy that not only kept them in certain places between racial zoning, which essentially steered people by law to certain neighborhoods, and racially restrictive covenants, which precluded people from selling to African Americans or other minorities, and then redlining, which actually stripped these communities of value and investment. More recently, it's become obvious that this is not just low-income people of color or people of color in general, that white Americans, particularly those that live in rural parts of America, are experiencing significant life expectancy changes and mortality changes. And two economists from Princeton, a husband and wife couple, Angus Deaton and Ann Kayes, who are pictured here, published, and Angus Deaton won the Nobel Prize in 2015, published this graphic looking at mortality rates now, which is the inverse of life expectancy. So from 1990, which is on the left, to 2010, they looked at rates of death across many developed countries. So from the bottom, you see Sweden, Australia, Canada, United Kingdom. The USH is United States Hispanics or Latinos, Germany, France, and then that red line up at the top is US whites. And you see this dramatic kind of outlier effect of US whites, whereas virtually every other major population in the world is experiencing, as we would expect, a decline in mortality rates over this 20-year period. US whites have not. US whites have now essentially are experiencing an increase in mortality. So the phenomenon that we're seeing in terms of poor health across the United States is really not limited to people of color. White populations are, the mortality rates are so bad, in fact, that we're no longer, as health disparities researchers, able to use white rates as a benchmark against which to measure the mortality rates of other populations. Dr. Eppel is going to get into this in much more detail, but what we've realized over the past few years is that what we're essentially fomenting with our policies, or I should say the absence of our policies in the face of abject need, is this notion of chronic stress. That's what's driving these adverse life expectancy findings that we're seeing both geographically and then in certain populations, including in so-called working class whites. And this notion of chronic stress or allostatic load causing wear and tear to the body that essentially causes, independent of people's behavior or their diet or whatnot, it causes aging, premature aging, which Dr. Eppel is going to talk about in the body. And you're seeing this concentrated in certain communities across the United States. We're all subject to stress. There are many stressors in our lives, and stress essentially exacts a significant toll on the body, and more stress exacts a greater toll. Again, I'm deferring to Dr. Eppel to explore this a little bit more. So in conclusion, and this is a much shortened version of a much longer talk, as you could probably ascertain, what we've had to do is expand this notion of how we understand what creates health in the United States. The traditional approach is the so-called medical model, which says bad behavior, which is smoking, drinking, driving without a seatbelt, having sex without condoms, et cetera, leads to higher rates of disease or morbidity. And that those higher rates of disease lead to higher rates of death. And that's essentially the medical model. And that what we've recognized is that that's a $3 trillion expenditure, in our national ledger, and it's necessary, but it's not sufficient to explain what's actually producing health. And then if you go upstream and look at the larger society, you see that there are a set of biased beliefs that say that some people are just more valuable than others. That leads to policies and practices, primarily institutional policies and practices, that create communities. And I showed you maps from all over the country where you have communities where there are concentrations of adversity. And those concentrations of adversity are not accidental, they are man-made, and as one of my colleagues likes to say, they're man-made and they will be unmade by the work primarily of women. But what you see are these communities that are on life support. And from those communities, you have essentially a much higher proportion of patients that sort of move from the left into the right into that downstream cascade and end up with premature death. Our strategies to try to avert death are called emergency rooms. Our strategies to try to manage disease is called clinical care. Our strategies to try to change behavior is called health education. As I said, that's a $3 trillion enterprise. What we don't have are organized strategies to address communities that are on life support. We're working in California to build power in a critical mass of people in these communities and leadership so that they can participate in reshaping and holding accountable some of the institutions that are responsible for allocating appropriate health resources like parks and grocery stores, that all communities need to be healthy. We think that that's not sufficient. We also have to look at the policies, both health policies and the health implications of non-health policies. And we have to foster partnerships across the private and public sector to invest in policies and practices that produce health. We think that that's not sufficient either. We also have to change the narrative about what causes health and recognize that health is not just access to the doctor, nor is it about bad behaviors exclusively. It's also about the conditions that we create for people, and those conditions are policy-mediated conditions that are amenable to improvement if we can invest in policies that create real opportunity for all people. So I'm going to stop there and turn to Dr. Eppel, and happy to take any questions later. Thank you.
Thank you so much, Dr. Eichen. Dr. Eppel, maybe you could take this down to the level of our DNA, and this has been such a sweeping overview, an excellent overview from Dr. Eichen.
Thank you so much, Dr. Eichen. That was an amazing amount of important critical history for public health, and that you have been a pioneer in. So it's an honor to speak after you. I'm going to, it's also an absolute pleasure to talk to journalists. You, of all professions, have more access to shaping the narrative, to shaping beliefs about health, information about health. So it's, the goal of our work, of course, is to be meaningful to you so that you can disseminate information. So I am going to talk about race and place, and really, how these get under the skin to affect disease and aging. But I'm also going to take this opportunity to talk about what is stress when we refer to it in science, when we refer to it to the public, to a friend. I think we can do a lot better to break that down into a more meaningful ideas that can help people, help them understand health disparities, as well as help them in their personal life. Okay, so here you can see the longevity gap. Here you see life expectancy by race and sex. And there's a lot of gaps here. So one is the sex gap in longevity, which it used to be 7 years in the United States. It's now 5 years. It's a very reliable sex difference across the world. So clearly there's a lot of biology in this. Women come with 2 X's, 2 chromosomes. There's thought to be a lot of protection in having the double copy. There are hormonal differences. Estrogen is protective. There are behavioral differences. Men's psychology leads them to do more risky behaviors, to die earlier, to rely on alcohol and other substances more. So there's a lot to unpack with the sex difference, but then let's compare that to the race difference, the gap between longevity in Blacks and whites. We can't say that there's this huge genetic difference. And you can see, if you look at the white line, the light blue line of whites and the black line for Blacks, that there is a consistent gap in years of longevity. As an aging, well, so Dr. Eaton mentioned this idea of stress, wear and tear on biological systems that can start early in life. Next slide. I want to show you the latest study on this allostatic load and race. This is by Anthony Ong, O-N-G, from last year. And one of the things that we understand to be true is that life expectancy it's important, but it's a very crude marker. When we look inside, people don't get diseases at 50. They actually have biological dysregulation starting at a very early age due to their social circumstances. So this is a slide of allostatic load, so kind of a summary measure of how much biology is dysregulated from a normal baseline in Black and whites. And what you can see is that, or sorry, this is showing you what the effect of everyday discrimination is for African Americans. And this daily discrimination is different, is a new important measure to look at. So this is showing you that high levels of daily discrimination are related to higher levels of biological dysregulation. And this is controlling for education, income, for lifetime history of discrimination. So there's this ongoing process that is still unfolding throughout life trajectories that is related to ongoing biological dysregulation. I'm going to shift, that's my systemic slide, and now we're going to talk about what's going on in the cell. But first, let's think about what does this mean for health, for the quality of life. Next slide. So what determines longevity is somewhat different than what determines how many years of healthy living we have, health span. Now, we all know that years of living long is not worth much. In fact, we don't necessarily want that if we're going to be suffering and disabled and coping with multiple diseases of aging. So what really matters is how many years we have of healthy living, health span. So here you can see Jane and Mary have the exact same life expectancy, 80 years old, but Jane has lived for 20 years with chronic disease. Mary has compression of morbidity to the end of life and has led a much longer health span. And so that's what we want to be thinking of, is how can we think about the determinants of health and compressing disease. Now, I also study longevity, and I can tell you that the biggest, there are questions about, well, how long can people live? Can we move the needle on maximal longevity? And as of now, the big story is, well, we really can't unless there are major biological breakthroughs in the biology of aging. And we don't, well, I'm just going to say there's nothing in near sight. And what we do know is that even the best anti-aging pill available, there really aren't any, but let's just say metformin, which is something commonly taken here in the Bay Area for anti-aging. It reduces insulin resistance. That pill that attacks one pathway of aging does nothing for diabetics who are still eating a lot of sugar. Our behavior, our health style is more overwhelming than any pill can be. So we're still not going to solve aging unless we look at what's really happening in the lived experience. Next slide. So we have these two forces. We have advances in medicine and public health that has pushed our life expectancy so high that we're living close to average lifespan of in our 80s. So this is dramatic, but at the same time, we have dramatic health disparities from social inequities, from toxic stress, especially early in life, and from unhealthy lifestyle. And that's the low-hanging fruit. Just as you've seen, the largest patterning on public health is these negative forces that are malleable. Next slide. So there's place. There's two neighborhoods. That's a true picture back to back. And the density of toxic effects on health are, they come from and live in the context of poverty and poor neighborhoods. And so when we think about stress, what are all the different types of stress that we're exposed to in our lifetime? So we call this the exposome. So in contrast to the genome, the exposome is all of the different influences outside of our body that are impacting our health. Next slide. So when we think of the social stress exposome, you can see that there are many different types of exposures that go in the category of stress, but they are shaped from and stem from our environment, our home environment, our neighborhood, the safety of our neighborhood, the resources of our neighborhood, either the food deserts and the being surrounded by sugar and a toxic diet, or being surrounded by easy access to healthy food, for example. Chemical exposures are absolutely in a dose response with poverty and zip codes. And so we are also exposed to chemicals like phthalates, plasticizers, chemicals that are mimicking hormones. They're called endocrine disruptors. These are patterned by income, by neighborhood. So this is something that's invisible, that it's in a silo of environmental health, but it's absolutely interacting with neighborhoods and psychological stress. Stressful events and traumatic events are also patterned by neighborhood, and the types of positive and protective relationships. So these all filter into an experience or feelings of psychological stress. Now, as a stress researcher, if we just measure something like feelings of stress, that is just a tiny piece of experience. Next slide. So when we think about stress, we can think about it in three categories. There are these exposures, there's events, there's socioeconomic status, there's chronic stressors like chronically stressful jobs that are overwhelming or demanding, conflictual relationships and marriages, caregiving. So those are what we think of as chronic stressors. And the context for these are where we live and spend our time: home, neighborhood, institutions. Then there's the feelings of stress. And let me tell you, that's not a reliable way to measure health disparities. People adapt to what they see around them. So that's just a tiny feelings of stress is what we have relied on a lot in research, but it's really just one independent measure of stress. And then, of course, there's how stress gets under the skin to impact our biological regulatory systems, like this measure of allostatic load and these measures of cellular aging that I'm about to show you. So these three layers of stress are really different. They're not that strongly related. So when you hear studies about stress, we want to have some specificity. What are they really saying? You might see a study that says stress is not related to mortality, or stress is related to mortality. What are they really measuring? So I'm going to give you our most complex and sophisticated model of how we think about stress and health today. But first, next slide. Let me just point you to a website that my colleagues and I in the stress field have been developing over the last 4 years. We call this, it's an NIH-funded stress network, and we're about to launch next week. It's for researchers, but really this is going to be a useful source to journalists and scholars, anyone interested in, well, what is this measure? I'm looking for a measure, for example, of discrimination. What's most used? What's related to health? So you can see that there's past measures of stress that you can that are important, and there's also current measures of chronic stress, such as neighborhood safety and discrimination. So this will hopefully be a useful resource. Website's listed here. Next slide. So this is a paper that my colleagues and I just published this year from the Stress Network, and what I want to point out here is that when we think about allostatic load and aging, so the far right-hand boxes, it's really, there's never a simple model, there's never one predictor, but rather the context of what one has come with on the far left side, all the blue boxes, these are huge determinants of health. And this is contextual factors like socioeconomic status. There's cumulative stress that really matters. So particularly childhood adversity that shapes how people react to the next moment. And of course, there are strengths and resilience factors. So this history of experience, this context, shapes how we view unfolding experience. And so this whole circle in the middle, this yellow circle, is our day or our moment. So how we're responding to whatever happens psychologically, biologically, these are shaped by our history of trauma, our history of adversity. And these are then repeated processes that unfold over the day and lead to allostatic load and cellular aging. So so when we think about neighborhoods, that light blue triangle and the health behaviors, these are all shaped by where we live and how we grew up. Next slide. Early childhood adversity is one of the most reliable predictors of adult health, early onset of diseases. So these are some reports you can see by National Academy of Sciences and by the CDC. So, it's rare that we can say everyone agrees on this, and this is a public health risk factor in the stress field, especially since it's hard to measure stress. But this is one reliable, consistent finding about ACEs, adverse childhood experiences, add up in a dose response way to predict poor early mental and physical health. Now, we like to rather than wait to measure disease later in life, it is useful and helpful to look under the skin and look at rate of biological aging. Next slide. So these same ACEs that predict long-term outcomes are related in childhood and adulthood to measures of biological aging, telomere length, systemic inflammation in the blood, and the epigenetic clock. Next slide. So I see in the ad for this, it said you're going to learn about telomeres. So with the little bit of time I have, I'm just going to say that telomeres are one of many pathways of how we age. So these orange lit up ends on the tips of the chromosomes are packets of DNA that don't code for genes, but rather protect our chromosomes. They shorten with age, with cell division, and with stress, with the chemical environment in the cell being when it's higher in stress, and I mean as widely biologically defined as possible: oxidative stress, inflammatory factors, stress hormones, high insulin and glucose. These are all biochemical factors in our body that are associated with a faster wearing down of these telomeres. Next slide. So this is one marker. When telomeres get too short, our dividing cells can no longer replicate and replenish tissue. I'm going to say that these are small effects, but biologically well understood. I've listed 3 other pathways for understanding how we age through the lifespan: inflammation, poor mitochondria, and accelerated epigenetic clock. And what we now know is that exposure to traumatic stress and or PTSD symptoms are associated with all 4 aspects of biological aging. So there is little question in my mind that when we think about biological aging, we know there are many different drivers, but toxic stress is one of them that shows up consistently in data. Next slide. And when we think about the imprints, the long-term imprints of early childhood adversity, which has been called hidden wounds, biological embedding, that there are these young developing brains are shaped by traumatic experiences. And here you see in front of you some of the images of children being separated from their parents, and many still separated. And so not only is this morally wrong, but this is, from what we know from science, creating sometimes irreversible, but long-term changes in their brain, in their affective circuitry, in the biological set points in their body. Next slide. Okay, so lots of people might say, well, is telomere length a marker or a mechanism of aging? So let me just point to, there's just now many animal studies that show experimentally that when we manipulate stress in animals, mammals, birds, we do see a more rapid telomere shortening over that animal's lifespan. Next slide. There's now been many different studies showing that different stress exposures, and in particular psychiatric disorders, are associated with telomere shortness, and some of these are associated with predicting greater rate of shortening. Next slide. Okay, so this brings us back to the theme of the day, which is our environments. So what do we know about neighborhoods and telomeres? We have seen, there are many large population-based studies now that have quantified the quality of neighborhoods. You can look at aesthetics, broken glass, feelings of trust versus feeling unsafe, the resources in the neighborhood. So there are different ways to calculate it. And regardless of how you calculate it, most of these studies have shown that lower quality neighborhoods are associated with having shorter telomere length for the inhabitants of those neighborhoods, regardless of their personal income and education and other social demographics, and even stress levels. I focus a lot on stress, but these are, let's just say, invisible environmental stressors that get under the skin and are not necessarily indexed by asking someone how they feel. This is independent. In terms of all the different ways we can measure the quality of someone's neighborhood, feeling safe in your neighborhood is more consistently associated with the poor biomarker health than the other aspects. And that, of course, that shouldn't be at all surprising, because at the core of wellness is the need to feel safe, the need to be able to be at ease, to let your body have restoration in all of its cellular mechanisms of maintenance. Next slide. So I'm just going to show you the latest paper on, or one of the latest papers on telomere length and neighborhoods and race. And one of the things we know about race is that it's very confounded, of course, with place and with socioeconomic status. And the telomere story has shown us that. And Arlene Geronimus, who coined the term weathering, has shown that in Detroit, poor neighborhoods are associated with shorter telomere length, and they help explain the race difference. Here you see that there's a measure of neighborhood disadvantage. That's the distribution is completely shifted in the African Americans compared to the whites. So they're living with a more dense exposure to disadvantaged neighborhood. And in turn, they can explain the race difference by showing that neighborhood disadvantage is related to telomere shortening in a lawful way, in whites, in blacks, and it helps explain the shorter telomere length in African Americans. Next slide. So I will just, I have two more points. One is just how complex social stress is. I also study individual health behavior interventions and how we can move around biomarkers. And while those are proof of concept studies, they will never tackle the immense problems that we need to work on and solve, which are at individual, community, and policy levels. Next slide. So I wanted to end with an example that is gives me a lot of, I guess, excitement about the idea of multi-level interventions, the idea of interventions that both change the environment and also help at-risk individuals. So sugar is a pathway for health disparities. We know that refined or added sugar is associated with greater risk for diabetes above and beyond any other nutrient. I wouldn't even call sugar a nutrient, it's added. African Americans, men and women, have the highest level of added sugar. It is surrounding them in their neighborhoods. They're targeted with ads and with price leveraging. Sugar is also partly, I'm going to say, for people who are prone to it, it can be addictive. Next slide. So at UCSF, we have banned sugared beverages from every one of our 5 campuses. We measured abdominal adiposity before and after a ban, with almost a year in between. And what we found was that there was a significant decrease in waist circumference and sugared beverage intake. And the people who benefited were people of lower socioeconomic status, such as service workers, because they were in environments like working in a cafeteria where they're surrounded by sugared beverages, free soda example. And when that was removed, they had dramatic improvements in their health. They did not increase or maintain their levels by bringing it from home, et cetera. So this was what I view as a social health disparities intervention. Next slide. So I will just end there, that we need these different levels of intervention. Next slide. And then I'm going to show you that I have been trying to update people on the relevant science through Twitter and through our website. And feel free to join our website newsletter. And if you are so privileged and able to go on a retreat, this is one of the things we've been studying that we think leads to kind of a dramatic boost in health. That some of our studies show that retreats can change gene expression and levels of telomerase. And so I have teams of colleagues where we work on both science and meditation, and beautiful places. Thank you.
Mm-hmm.
Thanks so much to both of you. This is really an excellent overview. Just want to remind everybody that you can send us questions for our two speakers through the control panel. And I wanted to start out with a question we've already received from journalist Michael Stoll. And he asks, how granular are available statistics that can be used to correlate poverty records such as ownership, residence, property values, etc., with health outcomes? Is the census block the smallest meaningful unit of measure, or are there other ways to get down to the block and lot? Has anyone done this research?
Yeah, this is Dr. Eitan. Can I be heard? Am I unmuted?
Yes.
Yeah, we can hear you. We can hear you.
Yeah. So the health statistics data, you can get down to the address, depending on what agency you're working with. I mean, usually there's a mechanism using geographic information systems to put random shifts into the location of addresses so that you can't get somebody's actual house, but you can get down within the block group, the block that they're living on. But generally, that's the reason to do that is to find something else, some other data variable that you can correlate with life expectancy down to that level. And there aren't that many. There's a lot in the census. There's a lot in sort of land use records. But you've got two problems when you try to get down to that small an area. One is that you've got to have two things that are on the same geographic platform, which is often difficult. And then you get into what's called the small numbers problem. In other words, if you don't have roughly 20 deaths within whatever that unit of measurement is, your calculated rates can be very, very unstable. So we tend not to go down below the census tract. We haven't found that block groups are all that useful for health data. But I think depending on what it is you're trying to ask, what you're trying to address, you can get down there theoretically. You just have a number of limitations that you have to contend with.
And we have a question from Janice Valenzuela, who asks, Dr. Eitan, do we know how the patterns you found across the U.S. compare to other countries or across the world?
Yeah, that's a great question, and we're actually actively working on some of that right now. We've got some partner researchers in Canada and one that's in Belgium that's doing some European work. And what we found, sort of the preliminary work, and it's preliminary to us. I mean, other researchers have been doing this for quite a long time. Is that while we have a social gradient in the United States, in other words, I showed you that correlation where you see a line, the slope of that line sort of descending as you move from wealthy neighborhoods to poor neighborhoods. The slope of that line says a lot about the level of inequity in that community. And what we found in Canadian cities and in European cities is that you do have a slope. It's just much flatter. So the absolute level of decline from rich to poor is much smaller. And what you find in general, and there are a couple of books written about this, is that the flatter the line, the higher the overall line. In other words, everybody benefits when there's less inequity. The more steepness to that slope, the lower the overall line. In other words, even wealthy people suffer when there's high levels of inequity. And we think that the slope of that line, the steepness of that line, reflects the general level of stress in that society. So flatter lines are relatively lower stress societies. Steeper lines, like you find in the US, are relatively high stress societies, and with a lot of income inequality and a lot of relative difference between groups of people.
Question for Dr. Eppel. Has understanding or improved understanding of these biological mechanisms helped you and other researchers design interventions? And is the science as solid on the intervention end at this kind of biological level as it is in just deciphering the causes of these problems?
There are many different lifestyle factors that accelerate biological aging, that increase inflammation, that shorten telomeres. And there are some interventions that show that we can improve these biomarkers with a concerted effort, with, let's say, an intervention that's, doing a class weekly for 8 weeks. And so, or doing an exercise intervention. So we've, for example, recently published several papers showing weight maintenance is related to telomere lengthening, being in a meditation retreat versus a control group, as well as Eli Putterman has done a study showing if you help caregivers, people caring for a spouse with dementia, become fit, go from sedentary to fit, they tend to have telomere lengthening. Now, those biological changes may be short-term, they might not predict actual long-term better compression of disease later in life. So we don't know, we use these biomarkers as a barometer of change, and whether they are meaningful in the end depends probably on maintenance of the health behavior. But in terms of, are these useful for understanding public health, I think the types of questions that would be also impactful, for example, this Gini coefficient, this idea that there's some countries and regions have a larger gap between rich and poor, showing that that's related to, or testing whether that's related to telomere shortening on average for the whole region, is yet another way of showing that income inequality leads to greater suffering and worse health for all. So we have lots of parameters to show that the bigger the gap, the worse off everyone is. But there is people tend to have a lot of interest, let's just say self-interest, when they realize that it impacts their own health. So those studies haven't been done, but I think the neighborhood studies on telomere length do show that there are environmental influences that could be shifted. There's also studies showing, or at least one study showing, more greenery, living in a place where there's more green spaces is associated with longer telomeres. Of course, there's these studies try to control for all the other confounds, but there's a lot that goes into where people live. So we need to think of modifying a lot of different factors.
Thank you. And Dr. Iton, a sort of similar question for you. You've talked about these historic patterns of poverty and discrimination, and obviously there's not like a pill you can take for that. But when you think about interventions, what comes to mind? You mentioned, children did better sometimes when they moved to better neighborhoods, but you can't move whole neighborhoods somewhere else. So what are the things that you and others are looking at when it comes to these sorts of policy issues?
Well, so I just served on a 2-year panel with the Gates Foundation and the Urban Institute asking that very question. And they brought experts from all around the country to work together for 2 years to come up with recommendations in that regard. And what we concluded is that, one of the most obvious conclusions is that there isn't one single thing. It's not a silver bullet. There are multiple contributors to this phenomenon over the history of the United States, and it's been an enduring pattern. So to undo it, we're going to need to use multiple different strategies. And one is to, to let people move, particularly younger children, to facilitate their ability to move to higher quality neighborhoods, because we've seen that the impact on children is it's basically cumulative. And the longer a child is in that neighborhood, the lower the likelihood that that child will be able to be, socially mobile when they get into adulthood. So policies that sort of favor families with young children in Section 8 vouchers, for instance, may be one small strategy. But then we have to work on improving the neighborhoods where you find so much concentrated poverty. And those strategies, in our experience in California, really relate to political strategies. You have to actually enhance the quality of democracy in those places and in the regions that they're part of in order for people to effectively advocate on their own behalf for improvements in the institutions that serve them, like the schools and parks and recreation and employment, et cetera, et cetera. We also think that it's absolutely critical in this country to tell the true story of how these neighborhoods became these neighborhoods, because what we haven't had in this country is truth and reconciliation around racial apartheid and genocide, quite frankly, with Native American populations. And if you don't tell that story, people literally think that these are natural conditions, that these things evolved by themselves, and therefore they don't have any responsibility for rolling up their sleeves and trying to improve them. And that's one of the attitudes I find most often from kind of lay audiences. It's that, well, I didn't do this, and these things happened by themselves, and so why do I need to invest my time and energy in trying to change it? So telling the story of how these neighborhoods evolved, talking about racially restrictive covenants, racial zoning, redlining, all kinds of patterns that pushed people into essentially disinvested places or land that was not productive. Those stories need to be told and understood so that we can also come together and try to figure out strategies to move forward. But I think fundamentally that, the goal is to, I like to joke sometimes, is to Canadianize the United States, which is to essentially develop a new social contract and start investing in those things that we know that all people need to be successful. Universal healthcare is the most obvious one of those. Affordable college and past the college, living wage employment, childcare, housing. All of those fundamental things are done in the countries that have much flatter social gradients, and as a consequence, they have better health, substantially better health, and our overall health is sliding in comparison to those countries on an annual basis.
So one final question for you, Dr. Iton, and then one for both of you. The one for Dr. Iton is, can you use other measures or proxies of health outcomes other than lifespan, such as health department complaint records or 911 calls? What are some of the other sorts of data that you might look to get at this? And then the question for both of you follows up on some of the ideas that you were just sharing, Dr. Iton, about how can journalists best tell stories about this and translate these really sort of sweeping developments, either taking place in neighborhoods and through policy or under our skin. How can journalists do a better job of helping to translate this for their communities?
Well, I'll just start off quickly and just say that, at least on the journalism side, Michelle Levander is one of the experts in this, and her USC Health Journalism Fellowship really does help journalists tell, what I've heard described as a landscape story rather than just these portrait stories. And so I've had experience working with journalists that have been trained under that program that tell very compelling stories. I think one of the ways to think about telling these stories is to tell comparison stories, tell stories about a tale of two cities or a tale of two places or a tale of two countries, and show the sort of overall difference in the impacts that has had. And that's obviously not an easy story to tell, but it's basically trying to shake people out of this notion that we can't do better than this, that this is somehow natural and foreordained. We have to think about the fact that we're really on a very downward trajectory in this country, and other places have figured this out and are doing much better and doing it for much cheaper than we are. On the health data, yes, there are a number of different measures that you can look at, including complaints. Now, the good thing about life expectancy is that you, as I showed you with the death certificates, you've got a universal database. Everybody on this phone call will one day have a death certificate. So you can't get out of this life without one. So it's a comprehensive database. Whereas complaint databases are sometimes incomplete and not reflective of the entire population. And when you do these kinds of analyses, you want to find some variable that everybody contributes to, not one that just some people contribute to.
Wonderful. I'll just add that I think the messages that our health, that our aging is actually much more under our control than we think and than we've been told. And so empowering people so that maybe they have had ACEs. 30% of the population has had ACEs. So I think there's a lot of negative ways to spin stories where people feel, well, they've already been disadvantaged, and so they're in a rut or a track and they're going to not much they can do about it. It's just absolutely not true that what we do in that day, in those next months, has an impact on our health. It's never too late. We see this with the biomarkers. We can move them around. People can put themselves on different trajectories. So when people are empowered in that way in their individual life, that is helpful for some. But I think what's even more powerful is showing the examples where there are changes in group health with group changes. So remembering health is contagious. We have so many examples of how social networks affect health, how emotion and stress are contagious, how we control our microclimate of well-being by how we treat others. And so creating a climate of support instead of a climate of stress, scarcity, instead of a hostile work climate, that applies to every group we're in, that we can get together as a group and talk about how we want to make changes, schools, institutions, churches. So like even just our example of ridding soda at UCSF, that has had a dramatic effect, and it starts with a group process of education and people realizing that the soda industry has tried to convince us that of false data, really. I mean, in the end, and that people, people need and should feel angry and take charge of their health. We're not going to have banned soda at any federal level, but you can certainly have it in the local and environments that you have a say in.
Thank you so much to our two distinguished speakers for this wonderful overview. We're going to end our webinar, and I want to thank our participants as well. We'll be sending you a survey shortly where we ask for your feedback on the webinar, as well as topics that would be of interest for you going forward. Please take a moment to fill it out. It's quite helpful to us. And I also wanted to let you know that you can see an archived version of this webinar, as well as a host of other resources on our website, centerforhealthjournalism.org, in a couple of hours. And to remind everybody that if you want to remain updated on our content and our webinars and other events, that you can subscribe to our newsletter at centerforhealthjournalism.org. Thank you all, and have a wonderful day.
Thank you.